Hi, welcome to the MWM show where we bring unique and empowering views on psychology and well being so that you get to enjoy great mental health. Today, we bring a conversation with Dr. Brian McElroy, who is a medical doctor with a special interest in mental health, integrative well being, and recovery. Now, Brian spoke to us at the Mental Wealth Mastery Summit in November 21.
So I think informed consent ideally would allow people to see that there are different ways of dealing with their distress, and not kind of funnel them into one or two specific choices.
In this very informative talk, Brian shares about the pressures of a salaried GP in the UK and why it is often a challenge to ensure optimal care, including good mental health care for patients. Brian also talks about how he uses his understanding of non-pharmacological approaches to offer wider treatment choices to his patients. Informed consent is a key pillar of good healthcare. Brian shares how he facilitates proper informed consent for his patients. So let's join Brian and Rani in this conversation.
Brian, welcome to the Mental Wealth Mastery Summit.
Thank you, Rani. It's wonderful to be part of it.
You have a special interest in mental health and you are a GP. And we all have heard about how busy the GPs are. And I would just like us to get started by you giving us a sense of what does it mean to be a GP in the NHS. So can you just give us a feel of your day-to-day work?
Yeah, sure, Rani. So right now I work as a locum doctor. Before that, I was working as a salaried doctor for 2.5 years. Particularly as a salaried doctor or a practice partner, it's incredibly busy work. So typically you have 30-ish patient contacts. So on my typical working day, I have about 20 to 24 phone calls, and then maybe 4 to 6 face-to-face consults. And what you're dealing with is a whole wide variety of things. So obviously you've got all the specialities mixed into one. So you might be caring for a dying patient in one consult. You might be referring someone to be investigated for suspected cancer in the next. You may have someone with panic attacks in the next consult. And then you may have a sore throat in the following one. So it's a whole mix of things. As well as that, typically you may have 30 to 60 blood results to sort through, letters to sort through, insurance company reports, medications to sign off. So it's a very busy, demanding job. And particularly when I worked as a salaried doctor, I was doing 10 to 11 to 12-hour days with very, very few breaks. It's a little bit, you could say, easier as a locum. It's different because you don't have the administration burden, but it's a really, really difficult and challenging job. And I think in terms of helping people meaningfully with their mental health, it's actually very challenging for anyone, whether you've got a special interest or not. It's very, very challenging to really give people meaningful advice, connect meaningfully with people within a 10 to 15 minute framework.
Yeah.
So I hope that gives you a sense of what it's like.
Sure, yeah. No, I have a lot of GP friends and I know how busy it is and how hectic it is. Thinking about people with mental health difficulties, what are the challenges GPs face when trying to support someone?
So it's a really good question, Rani, and I think it's not straightforward. So I think in the past, GPs would deal with the more severe end of mental health challenges and presentations. Over the last 20 to 30 years, I think it's been really pushed out to the public to see your GP if you're stressed, if you're anxious, if you're sleep deprived, if you are a whole lot of things, really. And I think culture has changed, like over the last, like maybe 50 to 100 years ago. If people were stressed or had really big internal difficulties, they may have tried to speak with a priest or someone else in the community. So a lot of that is now being kind of funneled into general practice. So within 10 to 15 minutes, you have to try and get a sense of what's going on for the person, what's led them to this particular presentation. So for example, panic attacks or feeling suicidal. And then you have to try and offer a meaningful solution or perhaps think about referral. And as GPs, I guess the traditional or the conventional approach is that for a lot of presentations, you're most GPs are thinking of 2 to 3 things. So they're thinking of lifestyle measures, they're thinking of cognitive behavioral therapy, or they're thinking of medications. So that's kind of the challenge, and not everybody benefits in a very easy to fit way into one of those boxes. And some people don't benefit from all 3, and they're not, I guess, in a severe enough depressive state or a severe enough anxiety state to be referred to a psychiatrist. So then you have to think again about what you're going to do and how you're going to support that particular person. There's less doctors working full time now.
Sure.
So a lot of doctors are working 2 to 3 day weeks. So it's more difficult for the patients. It's also more difficult for the doctors because, doctors do differ. So for example, I really try and emphasize non-drug-based treatments before considering antidepressants or anti-anxiety tablets, for example. But some of my colleagues wouldn't have that approach. So I may meet someone somewhere into their series of consults with the practice, which is typically made up of a team. And sometimes I have to kind of backtrack because sometimes the medication that was prescribed I may not have felt was completely appropriate, and I may get a sense that there is a really large or significant psychological dimension that hasn't been dealt with, or that this person hasn't seen something in a particular way that could be really helpful. But then somehow you have to try and untangle that in 10 minutes and offer what you think would be most helpful. And that's challenging for the patient, challenging for me, and may also challenge the doctor whose decision I'm challenging in that process. So it can become quite complex.
Say a bit more about why you chose the non-drug approach as a first step rather than prescribing medications when you see a patient.
So there's a few reasons for that. Personally, when I finished medical school, I had significant enough distress for a duration of 6 months or so that I would have fit a diagnostic criteria had I seen a doctor or a psychiatrist. And personally, I recovered outside of the medical model through something called Alexander Technique, and through meeting a holistic therapist and working really on seeing my mind patterns very, very clearly. So that was my own personal experience. And so people present to me with the same diagnosis or similar diagnoses. And that's really, I guess, you can't help but learn from your personal experience and be affected by that. I've also, I guess, have an interest in this area, and I've met many people who've recovered outside of the medical model from things like clinical depression or anxiety, or even people in the depths of suicidal crisis. So that affects how I think about things, and it also affects how I sometimes direct people, particularly at the first consult or the first meeting. I may often direct them to podcasts or books that I think would be meaningful for them specifically. I also think CBT can be really helpful, and other approaches, psychological approaches such as EMDR, eye movement desensitization, reprocessing. But I think that there are a lot of things that people can find helpful. I'm also a big advocate of high intensity exercise or fresh air, good quality time outdoors. So I think sometimes those simple things can be easily forgotten because the guidelines that we tend to adhere to can kind of funnel us into thinking about CBT or medication only. And they certainly have their place and can be very helpful for some people. But with medication, for example, I've had an interest in that area as well for over 10 years. And I've met a lot of people who describe the harmful effects of medication, whether they be side effects or a really painstaking approach to trying to come off the medication because of their withdrawal effects. So I don't rush into prescribing medication. I really try and slow the process down, give them some information, ask them to look up more information, and then come back to me and we consider a medication if there's no other options or if they've went down other avenues and they haven't worked. after 2 to 3 consults. So I'm not anti-medication. I see it as part of a plethora of choices that someone may use in terms of helping them recover from whatever they're going through.
We know that according to the GMC guidance, the GMC guidance does say that we need to offer people choices.
So I think to somewhat paraphrase the GMC guidance, I think it's about the person making a choice where they have sufficient information to make that choice, both the potential benefits but also the potential drawbacks. So that's extremely difficult when you've spent, the most part of your 10 to 15 minutes getting to know the patient, getting to know their story, and then there's something like 1 in 6 people in the UK are taking an antidepressant right now, and most of them are prescribed in primary care. So to try and facilitate informed consent in that limited time frame is really, really challenging. And not for any malice of any reason, but most GPs don't achieve it because it's almost an impossible task. Personally, I've tried to make my own kind of consent forms and made my own kind of documents to support that process. But even with that, that's still quite challenging for me to actually go through that with them. I'm really trusting that they have the time and impetus to do it themselves. And also it's something that it's not just the first consult. So it should be something that people are checked in upon regularly. And what I often see and what kind of saddens me is that some people take one antidepressant for a while, for a few weeks or a few months, and then they take another one, and then they take another one, or else their dosage is increased. And often no one actually stops to kind of consider, well, maybe this isn't the best approach. Maybe we need to take a very, very different approach. And I think when you step back from the situation, all of us know that there are so many factors that influence our mental health, such as what we've been through in our lives, our current relationships, whether they're supportive and nourishing, how much time we have for ourselves or for things that nourish us, such as time out in fresh air or time with loved ones, and what our beliefs are about ourselves and the world around us, and what our relationship with our own thinking is like. And so, for example, I think Dr. Bill Pettit is also being interviewed at this summit, and his story is really remarkable. He saw 6 psychiatrists and was being treated for clinical depression. But when he met a guy called Sydney Banks, who had an enlightenment experience and was able to share what he learned through that, he was able to see that he could change the relationship he had with his stressful thinking. And over time, the thinking itself changed naturally by itself. And I think that's what happened to me, in a sense, in my recovery experience. I needed someone to be a mirror to me and to reflect back how I was getting really, really caught up in my stressful thinking, and how I could kind of be more embodied and more in the present without that thinking, or in a different relationship to it. So I think informed consent ideally would allow people to see that there are different ways of dealing with their distress, and not kind of funnel them into one or two specific choices. And even if you are funneled into one of those choices, that you really know what you're getting yourself in for, because the evidence, looking at, for example, antidepressants, which are the most prescribed medications that we use, it isn't all that it's cracked up to be in many instances. So a lot of the effect seems to be effects that are non-drug mediated, sometimes called the placebo effect. But also the long-term studies aren't as favourable, again, as many doctors or patients would kind of preconceive them to be. And I think that's something that patients aren't often informed about at the beginning. And as you mentioned, maybe if they were informed about those choices, some of them, perhaps many of them, would consider, well, not rushing into taking a tablet and maybe giving things a bit more time or trying out some other avenues beforehand. It's limiting to just prescribe a medication and expect that that's going to do everything. But unfortunately, that's somehow the way a lot of people operate and the way some doctors operate. I think because one of the reasons, and this comes back to informed consent, one of the things that a lot of people think is that antidepressants, for example, work in a specific antidepressant way, that they somehow change something in this kind of like magical way that changes your biochemistry or your hormones, and suddenly you're no longer depressed. But really, that's not, in my view, that's not really how they work. And there's quite a lot of evidence to suggest that they work in specific ways. And maybe some of the way in which they work is by taking the edge off our emotions, our emotional numbing, which can be really helpful if your predominant emotion is one of extreme anxiety or extreme stress for a long period of time. It can be really good to take the edge off that, and many people describe that effect and don't want to come off their medication after 2 years or 10 years because they want to feel less intense emotions in a less intense way. But it's a different way of viewing how the drug works, because a lot of people think that once they start this medication and they're on it for 4 to 6 weeks, then their depression is going to come down in a nice kind of predictable manner. But that's not often the way it does work. And the longer someone takes it, then there is an element of adaptability and long-term tolerance to the medication as well. So people can end up on higher doses, and the higher the dose, the more the side effects can occur.
Yeah.
So it's not straightforward. There's lots of complexities in it. Yeah. And for me, I really like to step back and inform my patients as best I can, and really not rush into the choice.
Yeah. Okay. So Brian, if there's someone listening who, is going through stress and anxiety, or or low mood, and that might be diagnosed as depression, and they go to the doctor, prior to them saying yes to an antidepressant, because we are talking about informed consent, are there at least a few things they need to have in mind, or ask their doctor, or get information about before they start on an antidepressant, for example?
Yes, yeah. So I think if you're thinking about an antidepressant, so first of all, we've both mentioned alternatives. So really look into the alternatives, I would encourage, and it's different for different people. Some people benefit from changing their relationship, their job, their kind of life habits, for example. And we've mentioned a few of the others already. If someone's thinking of starting an antidepressant, really look into it in a little bit more detail. So don't just look at the conventional kind of websites with the kind of common side effects, but most people get on fine. There is a significant percentage of people who find taking antidepressant very, very challenging. So for example, akathisia, which is a sense of inner restlessness that can come about through any psychiatric medication, can be a really, really horrible side effect. And as we've both mentioned, withdrawal effects can be really, really difficult as well. There are other things like, for example, I had an 18-year-old female recently who had a miscarriage and who spiraled into a real crisis because of that miscarriage. And it was really interesting because she fitted the bill for clinical depression, very much so. She ticked all the boxes. So I kind of referred her for CBT. I shared some resources with her, and I asked her to read up about antidepressants. She started on the antidepressant, but she took it for about 4 to 6 weeks, and she went on holidays with her partner. She changed her job. I had a weekly consult with her every week. She didn't really find any benefit from taking the medication, and in the end she decided with her partner and with me to stop taking the medication. And when I posted this on a GP Facebook page, almost every single response, I got maybe 12 responses, was just start her on an antidepressant. Start her on an antidepressant. I would go with sertraline, or I would go with this antidepressant because it's got the best evidence base in pregnancy and breastfeeding. But I was almost shocked by the lack of kind of seeing things from a more holistic way with this 18-year-old, because from my experience, if an 18-year-old male or female starts an antidepressant, it can often lead to a cascade where people take those medications for long periods of time, or end up on higher doses. So I really wanted to kind of I guess look at things from a more holistic framework, and was looking for helpful hints from my colleagues. But unfortunately, I was just kind of met with, well, let's go down the medication route as soon as possible. So I think it's almost sad that as GPs, a lot of us have been conditioned to go down that route very, very quickly. And I think the fact that there are guidelines advocating for antidepressants is kind of part of why we do that, because we tend to adhere to guidelines. That's how we operate in many instances.
Yeah, as a well-informed consumer, as a well-informed person, even if your doctor thinks that this is the best for you, please check it out, sit with it for at least a week or so, discuss with your family, and look at what's the outcome you want. And if it feels like you've got the information, not just about the benefits, but also the potential risk, adverse effects and withdrawal, possibility of withdrawal symptoms, and then make a conscious decision. I guess the other thing is like, how long do I need to continue on the antidepressants after I get well? And ask all those questions, have those questions, like be curious, just be curious rather than assuming that doctors know best, because it's about, yes, doctors are doing their best, but it's also, every person's role to have it think about what they want from the medication and how long for and how they will know it works and that kind of thing. So thank you, Brian. I wanted to, before we end up, I wanted to ask you a bit more about some of the things you said, because you use a phrase called recovery beyond the medical model. So can you tell us a bit more about that?
Yeah, sure. So that's kind of one of my special interests, really. So recovery beyond the medical model basically means, you meet the clinical criteria for a diagnosis, for depression, for anxiety, for binge eating disorder, for panic attacks, or whatever it is. Now, in the medical model, as we've kind of talked about, we have very specific ways in which we operate, and we have a kind of list of things that we go through. Not everybody recovers that way. So I'm one example, but there are many other examples. So, for example, you and I are both interested in this idea of innate health and well-being. Many people you can read of so many success stories online. And I've met so many people in person who've benefited from integrating that understanding. Some people benefit from using mindfulness, and sometimes in quite an intense way. People really have to spend a lot of time, in contemplation or in meditation to help their minds calm down. Some people benefit from spending much more time in the natural world, maybe exercising, but not necessarily exercising, just kind of basically getting fresh air and connecting with natural things, because the pace of society can be really hectic at times. There's also another interest of mine is the work of Byron Katie, which again I've met many people recover from very intense distress through her 4 questions, which are somewhat similar to CBT but have also a little bit of a different flavour. So they're just some examples of ways in which people can recover outside of the medical model. Sometimes it's much simpler than that. Sometimes it's finding a group of people that are really and truly nourishing and out for your best interests. So that could be a church group, that could be charity work, it could be literally falling in love with a life partner who's really good for you. All of these basic things that we all know are good for us can be enormously important for our mental health. So that's kind of what I mean in terms of recovery outside of or beyond the medical model. And sometimes that approach is more sustainable, and actually, people I've met have 0 on their depression scores when they recover outside of the medical model, because they really do, as you mentioned earlier, they see their mind working in a different way. They see that their life works in a different way if they make different choices, or if they learn that they have more choices in how they respond to life's challenges or their particular challenges. So I think that's kind of a description of what I mean by that.
Thank you. I think this has been a fascinating conversation. Now, people listening to you and me might be on antidepressants, and they might be thinking about stopping antidepressants. What's your advice for anyone who's trying to stop or thinking of stopping medications? Yeah,
really good question, Rani. Thank you for saying that. So in the same way, I would say don't rush into starting an antidepressant. I really encourage people not to rush into stopping an antidepressant, particularly if they've been on it any longer than 6 weeks, for example. So do your research, speak with your doctor, and read widely on the topic. So, for example, there's a website called Surviving Antidepressant Success Stories, and you can Google that, and that will give you a sense of both that it is possible, but also that it can be really, really challenging. So people can get really, really significant psychological or emotional distress as a result of coming off their antidepressant, particularly if they do it too quickly or too fast. And also, it may be important to read up on it before you speak with your doctor, because many doctors think that you can reduce your antidepressant by maybe taking half for a month and then taking it every other day. But we now know, and there's kind of a growing but kind of recent evidence that shows that that's actually not the best way, particularly if you've been taking an antidepressant for a long period of time. So people need to often do it really, really slowly by coming down by about 10% per month or per 6 to 8 week period. Often you need to be very, very patient with the process, and slow it down when you find that actually you're getting really significant withdrawal effects, and maybe working on other parts of your life or lifestyle for a period of time at a certain dose before you reduce down further. But seek support. Peer support can be very helpful as well. There's a lot of online peer support available, and engage with your doctor as best you can, so that they can support you and give you the right medication in the right way for you to support you in your journey. Some people have no problem or little problems in the process, but for some people it can be actually really, really challenging and almost dangerous, because it can jeopardize their mental health if they do so too quickly.
Thank you. And I have heard a lot of stories about how horrible those physiological withdrawal effects can be. And there's also a fantastic leaflet by the Royal College of Psychiatrists called Stopping Antidepressants. So if you just Google Stopping Antidepressants and put Royal College of Psychiatrists, the leaflet will come up, and it says exactly what you need to do. Definitely print it out, not just for yourself, but also for your GP, so that you can work collaboratively with your GP and look at a plan that suits you. But the main key message is, please don't stop medications abruptly or too soon, because people might think, I'm doing it very slowly, and because they have done it over a month or two, but that might just be too fast for some. And I like what you said, don't rush into starting medication, but also don't rush into stopping medication. So it works both ways, doesn't it? Right, Brian, we're definitely over time, and I had more questions for you, but it will have to wait for another time.
Thank you, Rani. Thanks for the wonderful work you do and for organising this amazing mental health summit. Thank you.